Welcome to our webinar, A Patient's Perspective on the Latest Research from the ASCO and EHA meetings. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and this generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, we do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Guillermo Garcia-Manero, who is a professor in the Department of Leukemia. He is also the chief in the section of Myelodysplastic Syndromes and the deputy chair in the Translational Research, Department of Leukemia, Division of Cancer Medicine at Texas MD Anderson Cancer Center in Houston, Texas. Dr. Garcia-Manero also serves on the Medical Advisory Board of the Aplastic Anemia and MDS International Foundation. Welcome, Dr. Garcia-Manero. Thank you for joining us today.
Thank you very much for this opportunity. It's always great to work with AAMDS and everything that you do for our patients and also for us as clinicians and researchers, so we are grateful. So I was asked to review some of the data that was presented at ASCO and EHA this year, and the last couple of years probably have been the most important, at least in my career, when it comes to clinical progress in the treatment of MDS and AML. So it's really incredible to see that. I've been practicing for 20 years, and and for many years we had very little progress, and all of a sudden we are really going through major really discoveries that are really translating into a lot of new clinical trials. So there were busy ASCO and EHA meetings, and the AAMDS gave me a list of things that they wanted me to discuss. I have not prepared slides. I think that actually that probably will distract us from messages. This is oriented for patients and caregivers. So I'm gonna try to go through them slowly, and then I really look forward to the questions. So the first presentation, so we're gonna start first with the ASCO meeting. So ASCO is the American Society of Clinical Oncology meeting. This happens every year. This year, of course, because of the COVID, was virtual. And in general, is not the best or biggest leukemia MDS meeting. Usually this is EHA or ASH, but this actually turned to be a very important meeting with a lot of very informative presentations. So I'm gonna go through them. So the first one I was asked to review was about a presentation by Dr. Hauser in Germany with a new drug that was approved a few years ago called Glasdevik in combination with low-dose cytarabine. This is the so-called BRIGHT AML trial. This actually is a study that led to the approval of this compound, and it was compared to cytarabine. So basically on this study with Glasdevik, that is inhibitor of an important molecular defect in leukemia called the Hedgehog pathway, these investigators performed a study for patients that were older, not fit for intensive chemotherapy, combining this new compound, Glasdevik, in combination with cytarabine subcutaneous. This is what we call as low-dose Ara-C versus just low-dose Ara-C. This is actually an intervention that is very common in Europe, where they will treat older patients with high-risk MDS or AML with this subcutaneous low-dose cytarabine that is relatively non-toxic and can help stabilize the disease. Although the reality is that the outcome and the expectations are not that great with this cytarabine. So the study actually showed superiority of this combination with Glasdevik and low-dose cytarabine as opposed to low-dose cytarabine. But in my own personal opinion, this data now is superseded by some of the recent progress that we have seen with some of the other combinations that I will be discussing later. So I don't know how much of an intake this combination of Glasdevik and cytarabine has had in the community. Here in Houston has been limited, but it is a good option, I would think, for older, frail patients that may not be a candidate for, let's say, venetoclax type of approach that we will be discussing later. This, for sure, will be a better option just than single agent cytarabine. So this is an important armamentarium for a specific group of patients. The next presentation that I was asked to review is a combination of Glasdevik, the same drug I just discussed, with azacitidine for both patients with high-risk MDS or acute myelogenous leukemia. This was presented by Dr. Seidan in New Haven. And again, this is a nice concept because what we learned from the Glasdevik cytarabine was that this non-toxic combination was superior to a standard of care. Here, actually, the idea would be, could you combine this with a standard of care agent such as azacitidine that we use for patients with high-risk MDS or AML? And the data that Dr. Seidan and the investigators showed was indeed that actually this was a safe combination of Glasdevik and azacitidine that had activity, although I couldn't really follow very much from the ASCO presentation what was the reality in terms of the depth of response, the number of patients with complete responses, and so forth. And again, I think that this data may be something that probably will be second line compared to some of the new therapies that we will be discussing later. There was another presentation at ASCO that was really interesting by Dr. Singh, looking at evolving risk of therapy-related myeloid malignancies. And this is an important group of patients because this is what we call therapy-related MDS or AML. So these are patients that have developed MDS or leukemia after they have been treated for a solid tumor or lymphoma myeloma, treated with chemo and radiation therapy. We know that a percentage of patients actually may develop this type of leukemias. Unfortunately, this type of leukemia many times is associated with a poor prognosis because they tend to be mutated for a gene called P53, or they have complex karyotype that, as you know, are associated with a poor prognosis. But this is also changing because, you know, what is happening in the community is that many times now patients with solid tumor malignancies are not treated with the classic intensive chemotherapies that we used to treat, let's say, lung cancer or breast cancer, where we have now a lot of new innovative therapies, including immune therapies or kind of kinase inhibitors that are not your prototypical chemotherapy. So this was a very interesting presentation because it's showing two things: that the pattern of these therapy-related myeloid disorders is changing just because we don't treat now a lot of the solid tumor patients with a high-dose chemotherapy as we used to do. But also, interestingly, the survival of patients with these solid tumors or lymphoma myelomas is really improving significantly, where in a way we are starting to see more patients with these secondary leukemias, just because the patients now with solid tumors or these lymphomas are living significantly longer than expected. So I thought that that was a very interesting presentation that provides a new landscape and context for this group of patients with the therapy-related disease. The next presentation that merits discussion is an update on a drug that was approved a few years ago, known as CPX-351. So this is an important compound that is used for induction chemotherapy in patients with what we call high-risk secondary acute myelogenous leukemia. In a way, actually, some of these patients that I mentioned earlier that have therapy-related disease. So CPX is an encapsulated form of chemotherapy that put together two compounds that we have been using for many years. That is this so-called 7+3, where you have cytarabine and you have an anthracycline, let's say daunorubicin. So what the investigators at CPX did was to basically come with a way to encapsulate this compound so we could give it basically in a more precise way. And what these investigators found was actually that indeed in this subset of patients with high risk MDS, AML, many of them were older, etc., they actually had a really nice response rate and increased survival as opposed to what you saw with the 7+3, where actually traditionally this has not worked out that well. So it's important many times to do longer follow-up with this type of studies just to see what happens to the survival if the data actually stands as it was first reported. And I was very happy to see again on this follow-up by Dr. Lancet at the Moffitt Cancer Center in Florida that indeed actually the trajectories of overall survival showed superiority with CPX as opposed to 7+3. So this remains a very important piece of our armamentarium for patients with leukemia. The other update that was important at ASCO was a presentation by Dr. Komrocki, also at the Moffitt Cancer Center, with an update on the phase 3 medalist study. So many of you know that one of the drugs that was approved this year for patients with myelodysplastic syndrome is a compound known as luspatercept. So luspatercept is a drug that interferes with mechanism that we call TGF-beta. And this drug was approved this year basically because it's able to improve anemia in patients that were anemic with a particular subset of MDS that we call refractory anemia with ring sideroblasts. And you know, this data was presented in 2018, first at the ASH meeting, so it's already a couple of years out, and then again in 2019, and the paper came out in the New England Journal of Medicine that you know is the top journal in our field. And this was the first drug approved for patients with MDS in over 14 years. So this was a very exciting data. So the data that Dr. Komrocki and his colleagues showed at the meeting basically continue to support the validity of the findings, where you know the rate of response with this compound as opposed to doing nothing, because these were patients that had already failed a drug like Procrit or Aranesp, what we call as erythroid stimulating agent, actually was superior. So this is very important to have more long follow-up with these compounds, with these drugs. And again, a very important new asset for our patients. The next presentation actually was from MD Anderson, from my colleague, Dr. Maiti and Dr. Konopleva. That is a different way to give venetoclax. As you know, for AML over the last couple of years, one of the main things that has happened is the development and the approval of venetoclax. And traditionally, venetoclax has been combined with azacitidine. This is the famous VIALE-A study that's shown that patients with AML that were older in a randomized study comparing azacitidine with venetoclax versus azacitidine alone, that the doublet improves survival in a very significant fashion. But azacitidine is not the only hypomethylating agent, and indeed there is another one called decitabine that has been used and still is used, that is actually also perhaps by some groups preferentially used for patients with acute myelogenous leukemia. So here at MD Anderson, Dr. Maiti and his colleagues developed this combination of a 10-day schedule. So this is a more intense form of chemotherapy. This was actually pioneered by the group at Washington University in combination with venetoclax. So this is a perhaps more intense, more aggressive way of treating patients with AML as opposed to azacitidine and venetoclax, but it's a really powerful way to do this with results actually that are similar perhaps to what you will expect with like true induction chemotherapy. So this is very important data that requires a little bit of sophistication in patient admission to the hospital and so forth, but very, very powerful. The next presentation, and I believe actually that the AAMDS will prepare a summary of all these presentations that I'm going through, is a study done by Dr. George in Utah, where they looked at molecular patterns of reporting or testing for patients with MDS and AML. And this, for the audience, if you're patients, is very important because it refers basically to this issue of how do we analyze and test patients in centers. And what we're finding is that there's a big difference between academic research centers where, you know, if a patient comes, has a bone marrow test with cytogenetic and molecular testing, and we really utilize this genomic and molecular testing to make decisions in terms of prognosis, what is the type of therapy, what will be the potential for relapse or not with therapies. So this was a very nice study that is called the Connect MDS AML registry, where, you know, academic centers are putting data, trying to compare really what are the different patterns of testing, etc. For the audience, I think the message is that when you are treated, particularly in the community, you need to make sure that the doctor has access to this kind of technology, and that when they perform a bone marrow evaluation, not only you're receiving cytogenetic testing, but also hopefully molecular testing. You should really inquire about that, because it's going to make a big difference in terms of your care and the treatment decisions, and perhaps also understanding of what your overall prognosis is. Following with the next presentation that I was asked to review is, again, follow up on this medalist trial that I was talking about earlier. This is the study with luspatercept. And here what they, Dr. Seidan and others were doing was to look at whether luspatercept, the drug that I was discussing earlier, actually had a benefit or not in a group of patients that we refer to as high transfusion burden. So these are patients that receive, for instance, more than 4 units in an 8-week period. So these are patients that are what we consider heavily transfusion dependent. And what we're learning with the luspatercept is that it has a significant activity in patients with low transfusion burden, but the data that Dr. Seidan showed that actually it also benefits, although to a lesser extent, those patients with a high transfusion burden. My take on this from this particular presentation is that luspatercept should be used probably earlier in the course of the disease, more than in patients with very advanced disease, but it still can help those patients that are really heavily transfusion dependent of red cells. The next goes back again to testing. It talks about disparities in the receipt of complete diagnostic evaluation. This is actually, in my opinion, very unfortunate that we see discrepancies and disparities based on socioeconomic status. Of course, that relates also to your capacity to be seen or not in an academic center and so forth. So I believe, and I work at a public university, of course, that you know, this is part of our mission, is not to really have this kind of issue where because your socioeconomic status, you may not be able to receive proper diagnostic evaluation and received of that information. So that is very important that we bring this type of awareness to the field, so we really do the best for all patients, particularly when we're talking about rare disease, that sometimes it may affect specific subsets a little bit more frequently than others. So I thought that that data from Dr. Mukherjee is actually really important. This is out of Cleveland Clinic. The other study that I'm gonna discuss is a study by Dr. Atala in Milwaukee, the Medical College of Milwaukee, looking at a drug that I helped develop called prasinostat. That is a drug that we refer to as a histone deacetylase inhibitor. So this is a class of drugs that we have worked for many, many years. There are a couple of these compounds approved for other malignancies, but unfortunately have never been shown to really improve the outcomes of our patients with MDS and AML, even if the preclinical data and the early phase 1, phase 2 trials suggested perhaps that these combinations were important. So unfortunately, the data that I saw from the presentation from Dr. Atala with prasinostat in MDS using an attenuated schedule was promising, but we just heard the news that a very big study of prasinostat with azacitidine and AML had to be closed early because there was no hint that it was really benefiting our patients. The other concept that I'll discuss briefly is very important and is actually also out of the MD Anderson, was an idea of Dr. Borthaker here in the leukemia department, that is the use of decitabine as maintenance therapy in patients with what we call core binding factor leukemia. So core binding factor leukemia refers to patients that have an inversion 16 or a translocation 821. This is around 10–15% of the patients. In general, these patients have a much better prognosis than other patients with AML. They do very well with induction and high intensity chemotherapy, but still there are some patients that do not respond as well as we want, or they have suboptimal responses. And we can measure this at the molecular level because we can measure the amount of core binding factor that may be left over after we really treat these patients. So Dr. Borthaker came with this idea of giving this decitabine after the chemotherapy, the induction and consolidation phases. And this is very successful, particularly when you piggyback this to sequential molecular monitoring of these core binding factor abnormalities in our patients. So this is data that has taken around a decade for us to put together. And this is part of our routine where we actually give low doses of chemotherapy, in this case with decitabine, for those patients with core binding factor abnormalities. We're going to move to a presentation with a new drug that has been very exciting for the field. That is a very powerful FLT3 inhibitor. As you know, FLT3 mutations is one of the most common mutations in acute myelogenous leukemia. And a drug known as gilteritinib was approved for patients with advanced refractory leukemia. And this is a study that we call the Admiral study. It was presented by Dr. Sasha Pearl out of Penn in Philadelphia. And it's, again, very nice to see that this small molecule compound, that is an oral compound, has such a degree of activity in patients with AML, and that those patients actually can go and have long-term survival outcomes with this particular compound. So, of course, this is one of the major problems that we have in AML, and being able to control FLT3 mutated disease is fundamental. We already had a drug that is a FLT3 inhibitor approved, midostaurin, that has shown in frontline studies to improve survival. And now we have a second compound, gilteritinib, that also helps patients with this particular disease. So we're looking forward to more studies in the frontline and with other combinations, really to establish the role of this compound in the standard of care for patients with AML with these particular mutations. Next, I'm going to move to a drug that we are all very intrigued and excited, that is called pevonidostat. This was presented by Dr. Ades from Paris in France. And this is a study that is what they call a phase 2 trial of the combination of azacitidine with an inhibitor of something we call NETylation, or NET8 enzyme known as pevonidostat. And this is a study presented by Dr. Ades looking at this ASA pevonidostat in patients with high-risk MDS or low-risk AML, meaning patients that have less than 30% blast. This is a very large international trial. The data presented here shows that the event-free survival and response rate are better with the combination of pevonidostat and azacitidine. And this is important because next year we should hear the results of a clinical trial known as Panther. That was the true randomized study of azacitidine with or without pevonidostat that could potentially lead for a registration on this compound. So this is very exciting data that we need to see maturing in this second study that we think will be presented before the summer next year. And we are all very eager to look at this data. Talking about important data is the presentation by Dr. Ravandi with a compound known as CC486. So CC486 actually is a drug that I helped develop for many years that is an oral form of azacitidine. So for many years, we wanted to have, in a way, a pill form of azacitidine because as a patient, you know that you have to come to the hospital 5-7 days a month, every month for many months for these drugs to really work. And if they do work, to basically to continue them for as long as they work. So this is a major effort for our patients. So an oral compound of azacitidine will be great. So this compound, CC486 or oral azacitidine, has been studied in MDS, I'll be discussing that later, and also in AML in a very important study that is called the Quasar AML 1001 trial, where patients that were in remission were randomized to receive further maintenance therapy with this CC486 or not. And this is really a key study because it showed that those patients that were treated with the oral form of azacitidine had a significant longer survival than those that got no therapy. So for a long time, we were looking to these maintenance trials, and you know, those studies are difficult to design, but this international effort with this compound actually was extremely successful, and in my opinion, very clearly demonstrate that the CC486 should be a standard of care when you finish your induction consolidation chemotherapy if you are not a candidate for an allogeneic stem cell transplantation. So for the audience, this data with the CC486 in AML and the update that Dr. Ravandi presented actually was really important and really establishes the compound or the role of this compound. So this is most of the data that we wanted to present from the ASCO meeting. Next, we're going to move to the EHA meeting. So EHA is the European Hematology Association. So there are basically two major hematology meetings in the world. One is the ASH, the American Society of Hematology, and the other is the EHA meeting, the European Hematology Association. They have a little bit of a different angle because, you know, practice patterns are a little bit different in Europe than the United States, but we find these meetings complementary and they're really wonderful opportunities to showcase our data. So some of these are redundant, so I'm not gonna repeat it. Some of them were, for instance, the same data in terms of Glasdevik and azacitidine or cytarabine. There was a very important presentation from the Japanese group by Dr. Makashima from Seishi Ogawa. This is a top group in Japan, looking at molecular alterations in these myeloid neoplasms, in particular at the mutation called DDX41. And I think the audience should be aware of this. So this is a mutation that happens in families. And what is important about this particular mutation is that it increases the risk of developing leukemia many years in your life. So this is not something that will cause leukemia when you're a kid, but when you are now in the 70s and 80s, you've been healthy all your life and all of a sudden you develop leukemia. Some people have this particular mutation. And this is important for practitioners because if you see that, then you may want to think about the family. Is it possible that a family member may have this leukemia, this particular mutation? This has implications also for instance, the choice of donor for a bone marrow transplant, etc. So this was a very important mutation. The message from the audience actually is the fact that going back to this issue that we were discussing earlier in terms of mutations, that is really critical to have this kind of genomic pattern analysis so you can figure out, for instance, if you have this particular mutation. It's a rare event, but could be really important to understand what you have and implications in your family and transplantation. There were also presentations at EHA in terms of luspatercept. So there was a presentation in terms of ferritin levels. So ferritin is a marker of iron accumulation. So as you get transfusion dependent, you accumulate iron. And one of the things that we try to do is actually to remove iron. Sometimes we do that with these chelating agents. And the data here by the luspatercept shows that basically because it decreases the rate of transfusions, it also decreases the level of ferritin. So this is kind of like a surrogate marker, but it's an important thing to see that provides further information in terms of the value of luspatercept for our patients. Another important presentation regarding this issue of anemia and responses was by Dr. Garilios and a group of investigators in North Europe, in Sweden, looking at quality of life and the use of these erythroid stimulating agents. This was important data, basically showing that, you know, as you increase your hemoglobin with these drugs, you improve quality of life. You know, this is interesting topic now because we live in these COVID times where there are fewer donors for multiple reasons. So our patients are actually living with significantly lower levels of hemoglobin. This is a major problem. And perhaps we need to really think about thresholds of transfusions for our patients. There was more data from Dr. Komrocki looking at further follow-up with luspatercept, but I already discussed that in the prior ASCO presentation. There was an interesting presentation looking at, for instance, combination of azacitidine and lenalidomide. This had actually been pioneered here at MD Anderson. Lenalidomide is a compound that is very effective in what we call del(5q) minus MDS. I think that this data with this doublet is not particularly interesting or something that I'm going to see our patients received. In contrast, actually, there were a very important presentation by Dr. Brunner looking at post-transplant outcomes at patients treated with a new form of immune checkpoint inhibition. These are drugs that we use for multiple tumors now, but that are coming into play also in myeloid malignancies such as AML and MDS. And this is particularly with a drug known as MBG453, that is what we call a TIM3 inhibitor, that is a new form of immunotherapy. This was very interesting data looking at outcomes of our patients that went through transplantation, showing actually that these patients did well with this kind of compound. And we're very excited actually to see more of these clinical trials with this particular compound in patients both with MDS and in AML. The next presentation that is really important is by Dr. Platzbecker in Germany with a new drug for low-risk MDS called imetelstat. And I believe that this data was just published in the Journal of Clinical Oncology, that is one of the top journals in the field. So this is a drug actually that inhibits something called telomerase for patients with MDS, and has been also used in patients with myelofibrosis and other myeloproliferative syndromes. But this compound has been shown to improve anemia in patients with lower risk disease, although it has some side effect that it can drop your white count and your platelets, but this could be actually a drug that could have significant role for patients with lower risk disease if this data is confirmed in subsequent clinical trials. So this is something to really keep in mind. The next presentation actually I had the opportunity to do at the EHA meeting was the first report of a phase 3 trial of CC486, that oral azacitidine that I discussed earlier, but for patients with lower risk MDS. So this was a very important study where we're, for the first time, gave in a systematic way these hypomethylating agents, in this case orally, for patients with low risk MDS. And the study actually has an unfortunate situation because what we found was that the drug resulted in significant improvement in anemia, in platelet count, decreasing significantly transfusions of our patients. So that was very positive, but it came at the expense, unfortunately, of early deaths in a group of patients at the beginning of the trial that basically neglected a potential survival effect that this drug could have had in this population that is at low risk. Now, it's important to realize that this group of patients with so-called low risk MDS actually were patients that had advanced clinical features, so they were not truly your characteristic lower risk patient. But of course, we don't want to have early toxicity and early mortality with any drug in low risk myelodysplastic syndrome. So this was a sad outcome because we saw good results in terms of the transfusions, yet because we had this early toxicity, early mortality, this at the end of the day did not help our patients. And that's why this drug is now approved for patients with AML based on the data that I mentioned earlier by Dr. Ravandi, but is not approved for patients with a myelodysplastic syndrome, even if it's a form similar to the azacitidine that we have used for so many years for MDS. Other presentations at EHA, including data with the ASA pevonidostat that I mentioned earlier. So you see that sometimes we go to a couple of meetings at the same time. Further updates also by Dr. Platzbecker with luspatercept in patients with MDS. Again, repetition of this issue of patterns of diagnosis in the European context. But there was an important presentation by Dr. Seidan, also from Yale in New Haven, looking at venetoclax in patients that had had the so-called hypomethylating agent failure or HMA failure. So this is combination of azacitidine with venetoclax for patients that had already been treated with an HMA. And unfortunately, what we found in this presentation is that there's not a lot of activity by adding venetoclax to those patients. So we really need to look for better alternatives research-wise for this group of patients. I'm just browsing through some of the other presentations that I thought could be of importance to discuss in the meeting before we have a time for discussion and open this to the audience. The rest of the presentation at EHA this year that were selected for this meeting really related to the impact of anemia and healthcare type of events, and also some further analysis in terms of testing and so forth in AML and MDS. So I'm gonna stop here when it comes to presentations, but I would like to do a summary of what's really happening both in MDS and AML, and then we can open it for questions. So we are going through really a transformation in terms of our ability to take care of patients with MDS and AML. You know, these diseases affect more frequently older patients that are not true candidates for high-dose induction chemotherapy or an allogeneic stem cell transplant. So until now, most of our treatment options were around the use of drugs like azacitidine or decitabine that we refer to as hypomethylating agents. And now, all of a sudden, we're starting to see very important combinations with drugs like venetoclax, APR-246 for patients with P53 mutated disease, magrolimab also for P53 mutated, but all patients, incorporations of new immune checkpoint inhibitors such as TIM3, the data with this compound pegonidostat that should read this year. So we actually expect that for high-risk MDS, we may have 2 or 3 new compounds in 2021 that could really improve in terms of what we're doing with azacitidine or decitabine. And then finally, and it was not on this presentation, is the approval of an oral form of decitabine, a drug known as STX727 or Incobi, that is a powerful way to provide by mouth a drug like decitabine. So this is really going to be very important for our patients. This drug was just approved a few weeks ago, allowing us to again deliver these hypomethylating agents orally. I think this is going to have a tremendous impact because it will allow us to have total oral therapies, to use this in the context, for instance, of post-transplant, where sometimes it's difficult to give these drugs IV. So in MDS, we're going through a major transformation that follows in a way where we're seeing in AML, where we saw the incorporation of BCL2 inhibitors like venetoclax, IDH1 and IDH2 inhibitors. By the way, those inhibitors also work very well in myelodysplastic syndrome. We mentioned the FLT3 targeted approaches with gilteritinib, midostaurin, and newer forms of chemotherapy like the CPX. That, together with advances in our ability to provide care, and very important, again, based on these early presentations, our ability to basically test molecularly the bone marrows of our patients is really allowing us to really determine prognosis and what is the best therapy for our patients. And as a patient, you should really demand this kind of knowledge from your doctor. What are my cytogenetic characteristics? What are my molecular characteristics? That is something that you should have in a frank discussion with your patients. And with that, I would like to stop here. Again, I'm extremely grateful to AAMDS for allowing me to present today. Hopefully we'll get questions from the audience. Thank you very much.
Thank you very much, Dr. Garcia-Manero. We have a few questions. With the approval of the oral Dacogen, do you foresee a future for oral Vidasa?
So this is a very important question. The oral Vidasa, if the audience is referring to CC486, is a very different drug than IV or subcutaneous azacitidine. So let me explain that very quickly. So the oral decitabine actually is 2 drugs. It's the oral decitabine plus a drug called cedazuridine. So when we combine these agents, what happens is we get levels in the blood of the IV, of the oral decitabine that are identical to IV. So in effect, when you're taking oral decitabine, you're taking the same drug as IV decitabine. In contrast, the CC486 is associated with a very small absorption, so you're getting a lot less drug. So right now, what we're thinking is what to do next with the CC486. We're planning a number of clinical trials to further elucidate the role of oral azacitidine. That said, there is a newer compound that is being studied in phase 1 trials that is called ASTX030, that is a combination of azacitidine with cedazuridine, and that drug actually may behave, we don't know yet, similar to this oral decitabine. So there are big difference in terms of the pharmacokinetic profile between IV subcutaneous azacitidine and the oral CC486 azacitidine. So the audience needs to be aware of this.
Thank you. With combination therapies being used more and more in treatment of MDS, do you see a greater future in using AML therapies to treat MDS patients? I think you mentioned that, but is there greater research of that connection for AML therapies to be more beneficial for MDS patients earlier on in treatment?
This is a great question. You know, both diseases affect older patients, and many of the AML patients indeed probably had MDS or they had a background of this disease. So the fact that we're approving so many drugs and combinations in older AML for sure is benefiting the MDS field, because in a way, many times these are the same diseases. We're just giving different names just because the percentage of blast is maybe lower in MDS, but the prognosis is not that different. And many of the ways that we treat this are very similar. So the question is very good, because that AML experience for sure is opening what we do in MDS. An example, for instance, being these venetoclax randomized studies that we have now in MDS that are trying to emulate what we did in the AML arena.
Thank you. With MDS typically being a disease of older individuals, sometimes when patients are diagnosed 75 or older, it can be difficult sometimes for patients to receive treatment. Do you see a future in studying treatments in older patients above the age of 75?
No, I think two things are happening. So one thing is we're starting to age much better. So for instance, in my center, we now sometimes consider transplantation to people in their 70s, 75. And we're much better, we're able to deliver better care. And also these oral compounds that we were mentioning, you know, a lot of these new drugs are actually oral drugs. They really are allowing us to treat in a safer, more efficient way our patients. So I think this is important, because when I started, you know, sometimes we will not treat older patients just because of a lot of things that go around at that age group. And now this has been very important to me, you know, kind of discrimination for age. But now we're getting much better in terms of how to deliver this care in a more efficient and I think humane way. And I think these oral compounds actually are gonna really help on that regard.
Thank you. You had mentioned about genetic testing. What is happening in that area? Will we be looking at possibly a future of testing other family members to see if they too may have genetic dispositions for MDS? This
is a complex topic, and most academic centers, they now have the so-called hereditary leukemia clinics. You know, solid tumor doctors had this for a long time. It was not that appreciated for the leukemia field, but now we know that, you know, this, by the way, I don't want to scare the audience, but we know that there are a group of individuals that are at high risk of having this kind of family type of risk that one could determine at the molecular level. But this requires a little bit of sophistication. It has to be done in a very careful fashion, because this has a lot of implications. So this is usually done in specific clinics. Now, what I'm trying to say is that not everybody needs to have a genetic assessment of risk, because majority of leukemia patients don't have that and the families are okay. But for instance, going back to that particular DDX41 gene, this is really critical, for instance, because if you are as a practitioner, if I see a patient like that, then automatically I will refer this to our hereditary leukemia clinic here at MD Anderson, because you know, you need to give the opportunity for those families to be tested. This has tremendous implications, for instance, in terms of, I was saying earlier, allocating particular donors, etc. By the way, not every DDX41 mutation is what we call germline, meaning that is in the family. So most of them, many of them are sporadic, but you just need to figure out actually if your patient has a germline or a sporadic mutation and so forth. And that again requires a little bit of expertise that is not commonly something that you can obtain, let's say, in the community. This most likely will require referral to a center where you know, they can really assess you.
Thank you. What are you most excited about for the future for patients who have the TP53 mutation?
We have these two great compounds, the PR246. That drug should read from a phase 3 trial in December. So in a month, we will know actually we have a drug that could help us in that context. And then there's also data with this antibody against CD47 called magrolimab that also has shown promising activity there. And by the way, if those compounds were shown to be positive, there is no reason why we couldn't combine them. So, you know, I'm optimistic. Of course, we need to see the data. We were part of those trials, but these are randomized studies, so I cannot share, nor do I actually have, the way these studies are designed are to blind us a little bit in terms of the output. But for the first time, we have two compounds that could be targeting this very difficult abnormality. So we are very excited. I think next year is going to be an important year when it comes to this.
Thank you. And our last question, what are you most excited about hearing about research with the ASH meeting that is coming up in December?
The abstracts just opened today.
Yes.
So I have not had a chance to go through all of them. I hope you invite me maybe, Julie, to present my take on ASH after the ASH meeting. I will be very happy to do that. This is going to be a really important year. First of all, it's very sad for us because, as the audience may or may not know, this is our annual gathering. So this is a bad joke, but you don't want to have leukemia or MDS diagnosed the first week of December, because that's when we all meet and everybody wants to go to the meeting. So this is going to be the first time that we do this meeting virtually, which is going to be different. It's going to be interesting to see how we disseminate information, how we advance the field, because the ASH meeting is the meeting where every year we learn what's happening and where the progress is, much more than ASCO and EHA. And there's going to be a lot of very interesting data for our patients with MDS and AML, with a lot of follow-ups with these new doublets, etc. So I can't wait actually over the weekend to go and start looking at this. But it's really important meeting for us.
Oh, great. Thank you so much, Dr. Garcia-Manero, for sharing your time and your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question or you have an additional question, you are welcome to send it to us in 3 ways. You can send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our program. Thank you, Dr. Garcia-Manero.
Thank you very much for the opportunity.
Take care now. Bye-bye.
Thank you.